How's it going, guys? Past level question, cardio, endocrine, step 1, family, internal medicine, 2CK. 57-year-old man comes in for follow-up appointment, blood pressure 190 over 100, 20-year history, hypertension, managed hydrochlorothiazide. 2 months ago at his lost office visit, his blood pressure was only 145 over 90. Fundoscopic examination shows AV nicking, arteriovenous nicking, just a buzzy phrase that means hypertensive retinopathy. A left carotid bruit is heard. Which of the following most likely explanation for these findings? Just whip the answer choice here. Choice A, Addison disease, wrong fucking answer. Autoimmune destruction of the adrenal gland, of the adrenal cortex in particular, which is going to cause low aldosterone and low cortisol. That's what you need to know, okay? So Addison disease is both low aldosterone and low cortisol. The low cortisol means you're going to have decreased negative feedback at the hypothalamus, anterior pituitary. CRH goes up, which means POMC, precursor to both alpha MSH, as well as ACTH goes up. So alpha MSH going to cause hyperpigmentation. ACTH is high in an attempt to stimulate the adrenal gland to make more cortisol, which it can. So low cortisol also means low blood pressure, because one of cortisol's roles is to upregulate alpha-1 receptors on peripheral arterioles so that norepinephrine and epinephrine can bind and cause constriction, so low blood pressure. And also the low aldosterone will cause low blood pressure due to decreased fluid retention. So low aldosterone, you're going to have decreased sodium, high potassium, low pH, low bicarb. And for low aldosterone, also, that means that renin would go up to compensate. Wrong fucking answer. Choice B, adrenocortical hyperplasia, wrong fucking answer. So this would give you a scenario where you've got the opposite direction of the arrows. So you'd have high aldosterone, high cortisol. Okay, it's usually a diffuse glomerulosa fasciculata reticularis hyperplasia. It could be one or more of the layers, but they're going to give you high sodium, low potassium, high pH, high bicarb. I should articulate that those classic arrow combinations, you should know that about 50% of questions on NBME for both step 1 and 2, your sodium can be normal. That'll trip students up, but your potassium bicarb will still be in the direction you expect. So this is classically not just congenital adrenal hyperplasia, the annoying 17-21-11 hydroxylase deficiencies, which I talk about in my high arrows PDF, by all means I'll link in the comments below, but this can just be seen autoimmune type disease. Okay, this is what's going to go down. They're going to tell you, for instance, that potassium's 3, normal range is 3.5 to 5, and you're like, well, that's weird. Maybe aldosterone's high. But then they tell you that MR/CT of the abdomen shows no abnormalities. So it means it's not renal artery stenosis, because CT MRI angiography would show an abnormality. It can't be a Conn syndrome, an aldosterone secreting tumor, because the CT or MRI of the abdomen would pick that up. So you're left with adrenal cortical hyperplasia as a possibility. They can mention autoimmune diseases. Okay, that's a proclivity, cause proclivity for hyperplasia of the adrenal gland. They can tell you the patient has Hashimoto, history of pernicious anemia, vitiligo. It doesn't matter. I've made YouTube clips on this. Wrong fucking answer. Choice C, Conn syndrome, wrong fucking answer. So as I just said, aldosterone secreting tumor. You pick this up on CT of the abdomen. You're going to have high sodium, low potassium, high pH, high bicarb. That's your classic arrow derangement. So that's literally all you need to know about that. It's not dramatic. Renin would be suppressed as a result. Wrong fucking answer. Choice D, pheochromocytoma, wrong fucking answer. This is going to be a tumor, benign tumor of the adrenal medulla, which secretes catecholamines, norepinephrine, epinephrine. It's going to present as paroxysmal, which means comes and goes. Paroxysmal hypertension, which can cause palpitations, headache. So they can tell you the patient has blood pressure, goes into the office, has a blood pressure of 120 over 80. And student says, oh, it can't be pheo. Well, it can be, because it's paroxysmal, comes and goes, meaning the patient gets stressed. Okay, so they can sit up on the operating table and the blood pressure shoots up, or they go home and then they get a palpitation, headache, their blood pressure shoots up. So it comes and goes. So that's norepinephrine, epinephrine secretion. And you need to know that you treat it with phenoxybenzamine, okay, which is an irreversible alpha-1 blocker. It's a long discussion. Don't want to go down a rabbit hole right now, but you don't want to give a beta blocker. You'll kill the patient. Okay, you got to give an alpha-1 blocker. If you give a beta blocker first, catecholamines floating around are going to have nothing to bind to but alpha receptors called unopposed alpha, and you cause constriction of peripheral arterioles, kill the patient. Okay, so you got to give an alpha-1 blocker first. Pheochromocytoma, part of MEN syndromes. Okay, the RET gene, RET proto-oncogene, so MEN2A, MEN2B. So both MEN2A and 2B share pheochromocytoma, medullary thyroid carcinoma, MEN2A, parathyroid hyperplasia or adenoma, MEN2B, mucosal neuromas, marfanoid body habitus. Wrong fucking answer. Should I see renal artery stenosis? Correct answer. So how do we know this? I'll tell you why. It's a key detail here. It's this right here. So the left carotid bruit. Now you say, I'll ask students, I'm like, what's like a bruit? And they're like, well, it's like a sound on a vessel when you auscultate it. Okay, but what's causing it? It's physical obstruction or narrowing due to atherosclerosis, almost always. Okay, so the inference you make here is, well, if the patient has atherosclerosis in one vessel, isn't it safe to say that he's going to have atherosclerosis in other vessels, the coronaries, abdominal aorta, popliteals, the renal arteries? Okay, so it's chicken before the egg, egg before the chicken. What are the risk factors for atherosclerosis? The high yield ones: diabetes, smoking, hypertension. Well, he's got a 20-year history of hypertension. That's his risk factor for atherosclerosis. So he's had atheromata building up within the renal arteries for all these years. And then it seems to be over the last couple months, that it's reached a threshold where he's now clinically significant for renal artery stenosis due to accelerated hypertension. Okay, it reached a critical threshold where now the RAS is kicked up significantly and we have an accelerated hypertension. Blood pressure is super high now. So that propensity is very buzzy. If they tell you that a patient's thrown on an ACE inhibitor or an ARB and gets a surge in creatinine or renin, that's also renal artery stenosis. If they told you instead, rather than like a patient over 50, they give you a woman classically 20s to 40s who has a narrowing of the renal artery, that's not renal artery stenosis. That's called fibromuscular dysplasia. Okay, it's not due to atherosclerosis. So this is a tunica media hyperplasia, despite the name dysplasia. So FMD in a woman 20s to 40s, atherosclerosis causing renal artery stenosis, generally patients over 50, risk factors such as diabetes, smoking, hypertension. You know the deal. I'm just going to make more content. If you like my stuff, subscribe my channel. I appreciate your time. That's it.